In this video, we are going to talk about the placement of the chest leads on the patient's body and the relationship of the chest leads with the heart and its electrical activity. And we'll try to figure out why we have some chest leads which are downward deflected more than the others one. Like if we compare V1 and V2 with V5 and V6, they have got a different morphology. We'll try to dig out what's the reason behind this difference in the morphology and what happens if these chest leads are not placed properly on a patient. So let's try to study chest lead placement in a patient. So let's see how the chest leads are placed and how they record the electrical activity of the heart. So this is a chest lead in ECG. So here we see this is a patient. So this is chest of the patient. First I'll draw a basic diagram over here. This is patient clavicle. This is patient clavicle. This is sternum of the patient. Okay. These are two clavicles. And in the center we have this sternum. This is a suprasternal notch here. So if I point it here, these are my two clavicles and this is a notch or depression just superior to the sternum. This is known as suprasternal notch. These are very important body landmarks. And also this is axilla. It has got an anterior axillary line and this one is the middle axillary line. This is axilla. It has got an anterior axillary line and middle axillary line. So let's try to draw a bigger picture taking the hero out of the picture. So let's take him out of the picture and draw the both clavicles here. Okay, this is sternum. This is patient's sternum. And these two are the clavicles. This is the left side and this is a right side clavicle. Okay, there is a very important bony ridges or there is when 1 to 2 centimeter below the suprasternal notch, there is a bony ridge which we call angle of Louie or manubrium sterni. So we call this angle of Louie or manubrium sterni. Manubrium sterni. And this is suprasternal notch. These are both clavicles. Now here parallel to the angle of Louie there is second intercostal space. Parallel to angle of Louie or manubrium sterni, this is second intercostal space. This is second rib and this is third rib. So the space in between these two ribs is the second intercostal. This is second intercostal space. This is a second intercostal space on the left side. This is second rib. This is third rib. So this becomes second intercostal space on the left side. Second intercostal space. This is left side of the patient. This is right side of the patient. So now the question arises, why so oftenly we refer that there is an angle of Louie? Because we want to reach to the second intercostal space. And how we reach there? We put a finger in the suprasternal notch, which is a depression or a hollow point over there, just above the sternum. We come down a little bit, 1 to 2 centimeter. We see there is a bony ridge. We can feel that bony ridge. That is the angle of Louie or manubrium sterni. Just parallel to the angle of Louie, there is second intercostal space on the right and the left side. So once we are there into the second intercostal space, then we go to the fourth intercostal space. This is the second rib, this is third rib, so this is the second intercostal space. Then comes the third intercostal space. Third intercostal space is between the second and the third rib. This is third intercostal space. Let me wipe it off and let me write it down. Third intercostal space. Third intercostal space on the both sides of the sternum. Again, this is third intercostal space. Then comes the fourth intercostal space. Both on the left and the right side of the sternum. These are the ribs. These blue lines are the ribs, and in between them there is spaces, intercostal spaces. So this is fourth intercostal space, both on the left and right side. And this is our destination point. First of all, we have located a suprasternal notch just above the sternum. Then we have descended down 1 to 2 centimeter and we came at a point which we call angle of Louie. Just parallel to the angle of Louie is the second intercostal space. Down comes the third and then the fourth intercostal space. Now fourth intercostal space is the point, is the place where we will put our first chest lead. On the right side of the sternum, as near to the right sternal border as possible. So along the right parasternal border, in the fourth intercostal space, we place our chest lead C1, which on the ECG paper will be V1. So in majority of the cases, it's mentioned or it's written on the ECG leads that this is C1, C2, C3, C5 and C6. So we are to place C1 or V1, whatever is mentioned over there, in the fourth intercostal space on the right side of the sternum near to its border. So now where we will place the chest lead 2? We place the chest lead 2 exactly opposite to the chest lead 1. We place the chest lead 2 in the fourth intercostal space, but on the left side of the sternum near the sternal border. So we place the chest lead 2. We place the chest lead 2 on the left side of the sternum in the fourth intercostal space along the sternal border. Now we do not place the chest lead 3 first. First we will have to place the chest lead 4 and then we will decide about the chest lead 3. Now where we place the chest lead 4, that is very important. This is fourth intercostal space and down comes the fifth intercostal space. This is on the right side, fifth intercostal space, and this is on the left side, fifth intercostal space on the left side. So please do not follow the anatomical landmark of the nipple. That is a very deceiving thing. But first look at these two clavicles. This clavicle which is on the left side has got a middle point. We drop a line from this center of the clavicle. This will be our mid-clavicular line. Where this mid-clavicular line bisects this fifth intercostal space will be the point where we are going to place C4. So we will place C4 in the fifth intercostal space on the left side of the chest at the level of the mid-clavicular line. Now between the C2 and C4 we will place C3 wherever it falls, but it should be between C2 and C4. So first we will place lead C2 and C4, and then we will place lead C3. Let's talk about where we place chest lead 5 and 6. Because we need fifth intercostal space for the placement of the chest lead 5 and 6. Let's wipe these things off here. So now we are into the fifth intercostal space. This is the fifth intercostal space, and here lies the axilla. One is the anterior axillary line and one is the middle axillary line. So this is axilla, this is the anterior axillary line, and this is the middle axillary line. So in the fifth intercostal space, on the left side of the chest, we place lead C5 in the anterior axillary line. In the anterior axillary line, this is anterior axillary line, we place chest lead 5 and we place chest lead 6 in the fifth intercostal space in the mid axillary line. So three chest leads, they are placed in the fifth intercostal space, C4, 5 and 6. Chest lead 4 is placed in the mid clavicular line in the left fifth intercostal space. Chest lead 5 is placed in the left fifth intercostal space in the anterior axillary line, and chest lead 6 is placed in the fifth intercostal space in the plane of the mid axillary line. So just to recap everything, first we locate the suprasternal notch, then we go down to the angle of Louie, which is a bony ridge. Parallel to it lies the second intercostal space. So oftenly doctors and students, they think that we are to place the chest lead 1 in the second intercostal space. No, this is a wrong answer. Why we then jump into the second intercostal space? Because this is easy to locate using the angle of Louie landmark. Then we move down to the third and ultimately reach in the fourth intercostal space, which is our destination for the chest lead 1 placement. We place chest lead 1 in the right fourth intercostal space near to the right sternal border, and we place chest lead 2 exactly opposite to the C1 in the left fourth intercostal space near the left sternal border. We do not place chest lead 3 first, but we place chest lead 4. Then we decide to place chest lead 3 between chest lead 2 and chest lead 4. Where we place chest lead 4? In the left fifth intercostal space, in the mid clavicular line. Do not use the word of nipple. And we place chest lead 5 and chest lead 6 in the fifth intercostal space in the anterior axillary and mid axillary line respectively. Now sometimes there is a dilemma that when the patient is a female patient and has got breast issue, the patient has a larger mass of the breast, then please do not put these leads on the breast. Put them under the breast, because you are not doing the ECG of the breast, but you are doing the ECG of the chest and the heart. So remember, place the chest lead 4, 5 and 6 underneath the breast tissue rather than on top of the breast. This is another very important point. So one thing to remember, that heart is located behind the sternum. So these chest leads, they are looking at the heart, the anterior wall of the heart in a transverse plane. They are looking at a strip of it. These are not behaving like the limb leads, because limb leads were looking from the frontal plane from the all sides. But these chest leads, they are looking at the heart from the transverse side. So this is an important concept, that the heart is located actually just behind this sternum. It is located like this, and these chest leads are looking at the heart in a transverse plane. So if you can recall the wave of depolarization, when it moves towards any particular electrode, it generates a positive deflection, and when it moves away from the any electrode, it generates a negative deflection in the ECG. Now if for a minute we take these bones away from here and we let the leads be there, and we draw the diagram of the heart and look at the correlation of the chest leads with the heart. Let's draw this diagram. First I'll take this bony landmarks off here. Okay, say these are atria, these are two atria, and this hole is the ventricle. This is septum. Heart is placed in our chest like this. It's like a fist. It is placed like this, that this is the inferior wall, this is the lateral wall, and this is the anterior wall. It is placed more like a fist. So the major portion of the heart is represented by the left ventricle, and which is lying sort of posterolaterally, and this small part is represented by the right ventricle, and this is septum. So if I place the chest lead as these were in the previous diagram, V1 is located here, V1 is here, V1 is located here. You can call it C1, you can call it V1. On the ECG paper, it is always as V1, V2, V3, V5, but most of the time on the ECG machine, the letters written are C1, C2, C3, C4, C5, C6. So you can use any either C or V on the diagram, but when you get the ECG, it is always V. So V1 is located here, V2 located here, V3 located here, V4 located here, V5 here, and V6 here. Now because these leads, these chest leads are looking at the heart, looking at the electrical activity of the heart in a transverse plane. They are looking in a not the frontal plane. So, and the wave of depolarization in the heart is going leftward and downward. If I make it here, it is going leftward and downward this way. So V1 and V2, they look at the electrical activity of the heart going away from them. So they generate, both lead 1 and V2, they generate negative deflections. This is lead V1, a small R wave and a deep S wave. This is V1 and this is V2. These are both negative chest leads because these leads have got a small upward deflection which is R wave and a deep downward deflection which is S wave. Why the downward deflection is deep? Because they look this wave of depolarization, net flow of the current going away from them. Why it is going away from them? Because the major portion of the electrical activity is represented by the left ventricle. These two chest leads are located anteriorly and this muscle mass is located posterolaterally. So the wave of depolarization is going away from V1 and V2. So V1 and V2, they generate negative deflections. But before drawing chest lead V3 and V4, let's draw V5 and V6. As you look at the diagram, the wave of depolarization is actually going directly towards V5 and V6. So V5, V6, they generate positive deflection. They have, this is a P wave because of little depolarization, small q, a tall S R wave and a small S wave, and this T wave. So V5 and V6, they are positive leads in the chest lead groove, because wave of depolarization is actually going towards them, but wave of depolarization is going away from chest lead V1 and V2, so they are predominantly negative leads. But what about V3 and V4? They are located right in the middle of these two extremes. So they see the current going towards them, and then they see the current going away from them. When the wave of depolarization or electrical activity is going towards any lead, they generate R wave. When it is going away from them, they generate S wave. So lead V3 and V4, they are as much positive as they are negative. Positive R and negative S, V3 and V4. So these are known as isoelectric lead, and this phenomena where we see the increase in the height of R wave as we move from V1 to V3, V4, V5 and V6 is known as normal progression of the R wave. So this is a natural phenomena, and what is the concept behind it? Because V1 and V2 are located on the right side of the heart, and its muscle mass, which is right ventricle, is a very small muscle, is like a pocket, and they are located anteriorly. The major portion of the electrical activity is represented by the left ventricle, and V1 and V2 both look at the left ventricle electrical activity going away from them, so they generate a deep S wave and a very small R wave. Why this is a small R wave? Because septal depolarization, initial septal depolarization is coming towards lead V1 and V2, because first the septum depolarized, this electrical activity comes towards them, but it's a very small or minor activity, so it generates a very small upward deflection known as a small R wave. But why they have a deep S wave? Because the electrical activity which is generated by the left ventricle, which is representing the heart, actually is going away from them, so they generate a deep S wave. But in case of the lead V5 and V6, they see the electrical activity coming towards them, so they generate a tall R wave and a very small S wave. Why they have a small Q wave, which we call the physiological Q wave, this downward deflection initial? Because this septal depolarization is going away from V5 and V6, so they look at this smaller activity, electrical activity or current or flow of current going away from them, so they generate a first downward deflection, this negative deflection, which we call physiological Q wave. But when the wave of current is coming towards them from the left ventricle, which is the massive mass, which is the major mass, they generate a tall R wave because of the same reason which the V1, V2 generated S wave, because this same current was going away from them. But in case of the lead V3 and V4, they are located in the middle of these two extremes. They see the current coming towards them, so they generate a R wave, but then they see the current going away from them, so they generate S wave. So these are known as isoelectric lead, and this whole phenomena is called the normal progression of the R wave. Now let's draw. Let's take this diagram of the heart out of the picture, and let's draw these 6 chest leads all together, so that the concept of normal progression of R wave is clear. So what's the morphology of the normal chest leads starting from the V1? This is something like this. V1P, which may be bifid, so it mostly it has, V1 has a P wave like this, upward and downward portion. A small R, a deep S, and then T. This is known as, this is V1. Then comes V2, small r, deep S and T. Then comes V3 and V4. Now the R wave becomes a little bit taller, but there also persists S wave. Then comes T. So this is V3 and this is V4, which has the height of the R and depth of the S almost equal. This is V. Now we go to the V, this is V4. Now we go to the V5. A first downward deflection Q, a tall R wave and a very small S wave. This is purely positive lead V5, and then comes the V6. So as you look at this diagram, you will appreciate one very important phenomena going on. As we move from V1, V2, V3, V4, V5, V6, the R keeps on becoming taller and S keeps on receding in its depth. So this phenomena is known as normal progression of the R wave. And if someone has lost this phenomena, that S is persisting in the V5 and V6, so this is a pathology. This would be a pathological thing. So normal thing is there would be a normal progression of the R wave if the leads are properly placed in the chest as I described their anatomical location. Now along with this, there is another very important concept about chest lead. Let me tell this thing. So let's draw the diagram of the heart once more, and let's place the chest leads over there according to the heart as we did in the last diagram. These are two atria. This is ventricle. This is septum. We place chest lead V1 here, V2 here, V3, then V4, V5 and V6. Now if you look at this carefully, you focus here, V1 and V2. Though all of these chest leads, they are looking at the anterior wall. But of the two, V1 and V2 are looking at the electrical activity of that part of the anterior which is very near to the septum. So the V1 and V2 are called, V1 plus V2 are known as anteroseptal leads. Anteroseptal leads. So when you focus on chest lead V1 and V2, though they are looking at the part of the anterior wall, but this is that part of the anterior wall which is located towards the septal side. So this is known as the anteroseptal leads V1 and V2. And if you focus on V5 and V6, though they are located in front of the anterior wall, but they are more towards the lateral part of the anterior wall. So V5 and V6 are grouped as anterolateral leads. V5, V6 are known as anterolateral leads, anterolateral chest leads. And V3 and V4, they are purely anterior leads. So when we talk about the cardiac ischemia, and we are to look for the ischemic changes, and we so oftenly hear these words that this is anteroseptal ischemia, this is anterolateral ischemia, this is anterior wall ischemia. This is because the group of the chest leads is subdivided into three categories. V1 and V2, they are anteroseptal and they are representing the septal changes and the changes of the right side of the heart. And V3 and V4, they are located purely in the anterior part of the heart. And V5 and V6, they are located in a position where they are looking at the anterior wall of the heart but from its lateral side. So these are known as anterolateral chest leads. But all in all, these are 6 chest leads which are looking at the anterior wall, and if there is any ischemia or any problem, we will be actually looking through these leads, and the changes which are in these leads will be telling us something about the LAD and the left circumflex artery. So these are chest leads placement, their basic concept and their morphology.